Okay, so this video is going to be going over how to schedule when a patient has a possible root canal. Okay, there's a couple different scenarios that we may run into, and you'll need to know how we need to schedule to put the right amount of time on the appointment book and also know what to put on the appointment itself so we know how much to collect on the way in. So it's basically there's two different scenarios that we may run into with this possible root canal situation. One is a patient might have an area of really deep decay. Two, it could be a tooth that has a crack in it. So let's go over the difference between those two. And actually, what we're going to do right away is just go right to the what the final answer is. Let me move myself up here. Okay. When it's deep decay, we will know if a root canal is needed at that first appointment. If it's a cracked tooth, we will not know if a root canal is needed until after the first appointment. And so, when it's deep decay, if it's a possible root canal due to deep decay, we're going to schedule for the root canal, along with probably a buildup in a crown that's going to be part of that treatment plan. But if it's a cracked tooth, we put down that they might need a root canal in the future, but we're also probably going to put down on the appointment or in their chart a buildup and a crown. Okay, so let's run through some of the basic clinical backgrounds on these cases to know why we would schedule things the way we do. So a little basic dental stuff right now. What is a root canal? So this video is geared towards front desk staff and those maybe new to dentistry who aren't familiar with how this works. So if you already know this, great. Just bear with me as I go through some of this basic stuff. A root canal is when the inside of a tooth, the pulp tissue itself, which is the blood supply and the nerve, that becomes affected or infected. I should say affected, meaning becomes irritated or inflamed. We call that a pulpitis. The kind of pulpitis that doesn't get any better, we call it an irreversible pulpitis, or it becomes necrotic, or the inside of the tooth dies, and that soft tissue basically leads to an infection that comes out through the root tip. Okay, so in this picture right here, you can see the root canal process play out. Someone has a deep area of decay typically. It gets down so deep it affects the pulp of the tooth. That then leads to, like I described, an infection. Now what has to happen is that insides of the tooth have to be cleaned out. So we make an opening through the top. We go in through the hollow part of the tooth, go down those little tubes or canals, as we call them, going right down the root. We clean those out with an endodontic file. We cleanse it with different cleaning agents. And then once the inside of the tooth is clean, we now fill it with this pink stuff. It's called gutta percha. It's just basically, think of it like it's a corking off material. We just go down and plug up those canals. That one picture does show a post being put in. Some dentists put them in, some don't. And then we have to they call it a filling, but really we call it in our office a buildup, because the next step for a back tooth, if it has a root canal, it's going to need a crown. So that's kind of the step-by-step process of what a root canal really is. And again, we could look at decay to see what might lead to a root canal. So here in the beginning, you can see in the first tooth, that's just very shallow area of decay. A simple filling will take care of that. We go all the way to the far end, tooth number 4, you can see that the decay is penetrated all the way through the enamel, through the dentin, has now affected and infected the root canal, or the actual pulp of the tissue, and that patient would then need a root canal. Teeth numbers 2 and 3. 2 is getting deeper than number 1, obviously, but it may or may not have reached all the way to the pulp. In this case, probably not. But in number 3, the decay is deep, but we don't know if the actual pulp is infected or affected yet. You can see in that example, it hasn't developed an abscess, so we would not see a dark spot on the x-ray. However, the pulp could actually be penetrated through with the decay process. So what does that look like here, like on an x-ray? So again, that little cartoon on the top left shows decay going through the top of the tooth, working its way down towards the pulp. Over time, that then travels down to the root tip and leads to an infection. This top picture right here, this shows, again, very shallow area of decay, deeper still, and this one, of course, is going all the way in. That has now led to this dark spot on the root tip, and we call that a periapical infection, or we may call it a tooth that has periapical involvement, is another way of saying it. But basically, the tooth is abscessed. Over here, you can see deep decay. Oh, I'm kind of in the way here. Let me move out of the way. Deep decay, and it's not a big bubble, but you can tell at this root tip, that dark area has started to expand, and that is the beginning of an infection. Down here again, you can see an area of, it looks like decay underneath an existing filling. And down here, you can see a big bubble. That would be a tooth that would need a root canal. And here is a smaller bubble right there. Here's another tooth that has a very large filling. These white things are called pins. Some dentists place those, and some don't. But I don't think that pin is actually going into the pulp. It might be, but most dentists would not drive a pin right into the pulp. But basically, it was very deep. And I think over time that this nerve inside the tooth has died away. The blood supply, the pulp has died away, and has now led to what these arrows are pointing to is this infection right here, this periapical radiolucency. And it looks like this is starting to widen as well. So this is starting the decay process. I'm sorry, this is the infection process. It's there, it's just this is more advanced and it's caused more damage at the root tip. If we take a look, however, at these cases, the decay is deep, but at least on these two, we've got periapicals. It doesn't look like the root tip is affected yet. It doesn't look like there's actual an infection process, at least not an infection that has led to the bone around that root tip from kind of dissolving away, if you will, because of the infection that it's trying to fight. Here again, deep area of decay, but the root tips look okay. This, I'm sorry, I don't have a PA, but we can see that the decay is penetrated through the enamel into the dentin, and here's the pulp. I mean, these are the situations where, as a dentist, we would go in and remove the decay. And you can imagine that if we keep removing the decay, which, by the way, when we get into these teeth, the decay is always deeper than what the x-ray shows. If it does go into the pulp, even though the patient had no symptoms, even though there's no infection, we still might do a root canal. So this would be one of those possible root canal situations. Up here, that's 100% root canal. I mean, we know for sure we're going to go in and do a root canal. That's a for sure. But on these, we might put down on the appointment book, that's a possible root canal. So we won't know until the patient's there. We have them numb. We will remove all the decay. If the decay goes into the pulp, if it goes into this middle area right here, or even all the way up into here, we have to clean that out. So we have to be prepared if it's a deep decay situation to do a root canal. Okay. And again, right here, just to kind of touch on this again, decay and pain sensitivity. Okay, patients often think that a root canal is needed if they feel pain. Well, yeah, if they have pain, yeah, they probably will need a root canal if they have deep decay. However, they conclude that pain equals a root canal, but no pain means no root canal, and that's false. I've seen so many patients along the way who have had deep areas of decay, didn't have any sensitivity, went in there, removed the decay, and lo and behold, we were into the pulp. And so they go, well, how can that be? How can I have decay going into the pulp, which has nerve tissue? Why don't I feel it? I don't have an answer for that other than that's just the way teeth sometimes respond. So it is incorrect to think that no pain equals no root canal. Deep decay can be asymptomatic. Be sure to address this with patients so they don't have any misconceptions. Okay, they may come in thinking, like I just said, well, if I had pain, I'd need a root canal. But if I don't have pain, then I don't need a root canal. That's not always the case. So that's why these possible root canals on deep areas of decay, that's why we schedule them for these situations. Okay, now let's move on to the second situation, which is a cracked tooth. So if we have a crack, again, it starts from the top, works its way down, kind of like decay. It starts from the top, works its way down. We don't know how deep these cracks go. There's no way for us to tell on an x-ray. We can't tell on a bite wing or PA. Not even on a cone beam, three-dimensional film, we can't see how deep cracks travel. I mean, the tooth is clearly fractured, that's one thing, but most of the time these are just small little hairline cracks that can run pretty deep, or they might be shallow. We simply don't know. And so these are situations where the patient may need a root canal if the decay has traveled, if the crack has traveled all the way down to the pulp to the point where the pulp is constantly being irritated due to that crack. This is what we see clinically. We take out an old silver filling, remove the decay, and you can see right here, there's a crack line traveling right across this tooth. You can imagine those two cusps, when the patient's biting, the buccal and the lingual, they almost want to spread apart like this. So when they try to spread apart like that, then that is constantly being irritated. If we could somehow cover those those cusps up by placing a crown over, and we can then hold the tooth together and it no longer has this flex. So if it doesn't have the flex anymore, then we can maybe stop this irritation from occurring. So let's review real quickly how this would work. Patient comes in for just a normal crown. Appointment number 1. They have some problem with the tooth. We have to then get the tooth prepped. We would take an impression or do a digital scan, send that to the lab. In the meantime, the patient has to wear a temporary crown. So right here, we make a temporary crown. It fits over the prepped tooth, and they're going to wear that while the crown is being made. It takes a couple of weeks. That's in the lab. The temporary crown is doing that job I just explained. If you have a crack in a tooth and you could fit something over it, whether it be porcelain or in this case a piece of plastic, it would do the job of holding that tooth together. So if the patient was having bite sensitivity because of an unprotected tooth or an uncovered tooth, when they're wearing this temporary, then if that was the fix, the final fix, then good, then the patient's symptoms should go away. So appointment number 2, right here, a couple weeks later when the crown has arrived, we take off the temporary crown and now we fit the final crown. Make sure that fits well, and then we put that in place. So that's going to be doing the same kind of job that the temporary is doing. It's holding the tooth together, but it is just porcelain instead. It's a much stronger material. If with the patient from here to here, meaning from appointment number 1 to appointment number 2, if they are still experiencing pain, then by simply putting a porcelain crown on the tooth, isn't going to change anything. They're still going to have irritation. So we would know while the patient is wearing the temporary if they would need a root canal, because you can't just put a final crown on and leave it. I mean, you could, but the problem you run into is if the irritation still lingers and a root canal is needed after you've already cemented this crown in place, we have to drill through the top of this brand new crown. We can do the root canal, patients can still keep the crown, but now they have this brand new crown that just has a big hole in it. That is, yes, been filled, but now you always wonder if the integrity of that crown or the longevity of that crown is somehow now compromised. So if the crack is shallow, then the threat to the pulp is minimal. A crown is placed to hold the tooth together and stops the cusp from spreading apart. However, a root canal may be needed if the sensitivity does not go away. So this brings us back to the very first couple of slides we looked at. Root canal scenarios. If it's deep decay, we will know at that first visit if a root canal is needed because the decay will have penetrated into the pulp. We'll see that and we can take care of it right then and there. If, however, the tooth is cracked, we won't know if a root canal is needed until after the first appointment, until after they're wearing this temporary crown. So how do we schedule for that? Real simple. On a deep decay possible root canal situation, we would schedule to do the root canal. We'd be prepared for the root canal, both in having the room set up and have the appointment and the finances and all that squared away. We go in fully expecting worst case scenario, and then we just go ahead and proceed as needed. If the patient doesn't need a root canal, great. We delete that off the chart. We delete it off the appointment. We shorten up the appointment. We don't collect as much as we would have because now we're just going to be doing a buildup and a crown, not a buildup crown and root canal. So we will make that kind of chair side decision during the middle of the appointment. However, if it's a crack, we do not schedule for the root canal. It's in the patient's chart. They're aware of it. They know that they may need it. But we're not going to put it on the appointment book because we're going to test the tooth out with a temporary crown. So hopefully this will help clear up some confusion when we're looking at trying to schedule patients who might need root canals. If it's a deep decay, like we mentioned earlier, that has already affected or infected the pulp and they have an abscess, we are for sure going to do a root canal. If they just have deep decay, we're going to go ahead and be prepared to do it at that same first visit. If it's a crack, however, we won't do it that first visit. We're going to see how they respond to the temporary first. Okay, so hopefully that clears things up, and I can get the appointment books squared away and get patients' expectations coming in to be much more accurate. All right, thanks a bunch.